Garmon. Dr. Garmon is one of us. She trained here through her anesthesiology residency from 2006 to 2010. I hope I have that right. A graduate of UTMB's medical school. Dr. Garmon has spoken and published relatively extensively on regional pain control and pain management issues, speaking at regional and national meetings regarding the subject. She is our director of the acute care pain management service, so a key resource for us. She's accomplished, obviously, from an academic and medical standpoint, but more importantly, she's a mother of 3, which I had to be reminded of that just minutes ago. I can recall one pregnancy during our time here together, but there were others that I don't remember. So that makes her the most dangerous weapon in her armamentarium as being mother. So in addition to a great physician. So it's with pleasure that I recognize Dr. Garmon for the Surgery Grand Rounds. So thank you, Dr. Garmon.
Thank you for having me. It's been almost 5 years since my last grand rounds for your department, and my topic then was widespread opioid overprescribing that contributed to the epidemic of misuse, addiction, overdose, and death. And the emphasis then was responsible prescribing to prevent those poor outcomes. But today's topic is buprenorphine management in the perioperative period for those who are already affected by opioid use disorder. So my objectives today are to explain the complexities of opioid use disorder management in the context of the current state of the opioid epidemic. We're going to review buprenorphine pharmacology, including the benefits and drawbacks to whether it is used to manage opioid use disorder or for pain or for both. We're going to discuss evidence-based consensus recommendations for perioperative pain management in general. And then we're going to assimilate evolving recommendations for perioperative pain management in patients taking buprenorphine. And briefly, we'll talk about naltrexone as well. So I don't have any disclosures, but my usual disclaimer is I really care about this topic. Our society has been harmed by a few greedy and powerful people lying and manipulating public thought about opioids for their personal gain. But I think most prescribers are trying to do the right thing. And it's hard to know what that is because so many things are said. We've believed a lot of lies in the past, and new information comes about all the time that changes what we know about the topic. And although I may be critical of certain treatments, I'm criticizing in hindsight, which may not be fair, but it's all I know for us to do to learn from those mistakes and do it better moving forward. So first, what is opioid use disorder? It's a problematic pattern of opioid use causing clinically significant impairment or distress. And these symptoms have to be present for 12 months and they have to be related to the use. So you have symptoms of impaired control. You use longer than intended, you can't control, you spend a lot of time seeking or recovering, and you have cravings. You also have symptoms of impaired social functioning or risky use, which is like failure at work or school or home, interpersonal problems, reduction of activities, putting yourself in hazardous situations, or recurrent problems. And then you have pharmacologic criteria, but tolerance and withdrawal can't count as the 2 criteria if they come about from prescribed opioids under the supervision of a physician. So SAMHSA estimated that approximately 0.2% of the population in 2020 had heroin use disorder, and that translates to 691,000 people. And 0.8% of the population had prescription opioid use disorder, which translates to about 2.3 million people. But that's only a small percentage of people who actually misuse opioids. In the same survey, 3.3% of respondents reported past year pain reliever misuse, which is 9.3 million people, and 0.3% reported heroin misuse, which is just under 1 million people who misuse but don't meet the criteria for use disorder. So an estimated over 10 million people reported illicit use of prescription drugs and heroin combined. So you can also see that prescription opioid misuse and heroin misuse often occur together, more commonly if it's heroin than prescriptions. But all prescription misuse is that in the blue circle, and then heroin is in the yellow circle, and the overlap is the green there. And the last thing I want to point out about this survey data is that it again demonstrates that most misused pain relievers come from friends or relatives, either sold or given by friends and relatives, which is consistent for the past decade. And we can assume that those were leftovers from unused prescriptions, because you're not going to buy them off the street and then give them away. And you might argue that this reservoir of supply should be decreasing, because opioid prescribing is now at the lowest rate that it's been in 25 years. But I would caution you about how you interpret that claim, because the number of prescriptions dispensed may be back down to pre-1995 levels. But as this shows, the MME prescription, the morphine milligram equivalent per prescription, is still significantly elevated. It's half of what it was at the peak in 2011, but it's still 3 times higher than it was back in 1992 before OxyContin hit the market in 95. So it may be better, but it's still bad. And even though prescribing has gone down, patients still consume less than is prescribed, leaving leftovers. And so this data is by Brummett and colleagues from the Mission Open Prescribing Engagement Network. And it's been repeated multiple times over by other investigators. So back in 2017, they began intentionally reducing their pill counts at discharge. And so each of those red lines is a time point of their prescribing reduction. And you can see that as the number of tablets prescribed in the black triangles decreased, the number consumed also decreased. That's the black squares. And so no matter the quantity prescribed, only about 45% of the tablets were consumed. And what was interesting to me is that the reduction in prescribing had no effect on patient satisfaction, which is in orange up there at the top, or on pain scores, which is down there in blue. So, and the last way that we know that we're still overprescribing is that we continue to have so much excess that's still circulating in the community. So since 2010, the DEA has taken back over 8,600 tons of unused prescription pain pills in the US, and 600 tons just in Texas alone. And they're relatively unchanged in those numbers for the past 5 years. So this is just last month, and you can see it's relatively the same. And these collections are just the responsible people who actually deliver them, turn them in. But the bigger majority of leftover pills are the ones that you saw earlier that people are giving away to their friends and family, or selling to friends and family. So it's really at this point indisputable that overprescribing and inappropriate prescribing led to the opioid epidemic. And this is a great book that chronicles that from the very beginning. I highly recommend it to every resident before you finish your training, and take it as a warning to approach everything that you read with skepticism. And if it sounds too good to be true, it probably is. Like opioids aren't addictive. But that was only half of what Purdue Pharma tried to say. Their other claim was that opioids are safe when they're used to manage pain. But we know that's also a lie. You can see that death rates have increased in 3 waves. The first wave was the rise in the prescription overdose deaths. The second was the rise in heroin overdose deaths as prescribing decreased and supply dropped, and people started searching for a cheaper high and more available. And finally, then the third wave, which we're still in, which is the synthetic overdose deaths, which is primarily fentanyl and its analogs. And fentanyl is everywhere. It's estimated that about 250 to 500 million pills are circulating in the US at any time. And that's not even including adulterated powder drugs, cocaine, MDMA, those. And while we've been focused on COVID for the past 3 years, this has continued to get worse without much public awareness that it's really even going on. But it hasn't stopped it from killing people. During the pandemic. The preliminary reporting from the beginning showed that there was a substantial increase in drug overdose deaths, especially, again, involving the illicitly manufactured fentanyl, and that continues even through today. So as you see here, opioid death rates continue to increase during the epidemic, or the pandemic, I guess. The bars represent death rates in the US, and the blue line represents death rates in Texas, and both have gone up. And remember, this only represents deaths when opioids were specifically documented. This is likely greatly underestimated because up to 25% of death certificates don't have a drug listed because they occur in counties without a medical examiner. And so those are not reflected in this data. But you don't have to misuse opioids to die from them. You can take them exactly at the dose they're prescribed, at the interval they're prescribed, for the condition they're prescribed, and you can still die. And that's exactly what happened to my sister-in-law, Betsy. She had just called me. She was so excited. She felt better than she had in a really long time. She had cooked dinner and made a batch of cookies and been on her feet for 3 hours. Which hadn't happened in months. And she was really optimistic about the way she was feeling. And 3 days later, she was dead. She's my Betsy, but to you, she's just a data point on this graph here. And these bars represent 600,000 other sisters and brothers and mothers and fathers and sons and daughters who've been lost over the past 2 decades to opioid overdose. But the solution is not to stop treating pain. That's not what I'm saying, because suicide rates are also going up when opioids are abruptly discontinued. But what I am saying is that we need to treat pain in the safest, most evidence-based way, and we need to keep as many people as possible in treatment for opioid use disorder. And if we do that, maybe we can save people from accidental appropriate use overdoses, or hopelessness suicides, or misuse overdoses. So that brings us to the treatment options for opioid use disorder. So methadone is the gold standard for opioid use disorder, with the highest retention rates in maintenance therapy of any other treatment. It's a full opioid agonist with a very slow onset and a long half-life. It requires a daily observation for administration and maintenance, and that's done at highly regulated treatment centers. So that's pretty burdensome for patients. And the goal is to control the use disorder and restore healthy functioning, which is difficult with that degree of disruption. But because of the very slow onset and long half-life, there's a lot less euphoria than you get from rapid onset opioids like heroin, and that's what makes it so favorable or attractive for treatment for opioid use disorder. Buprenorphine is attractive because it is a partial agonist when absorbed through the buccal mucosa, but it comes as a combined drug with naloxone, which is active if you crush it up and inject it. And so it becomes inactive if you try and misuse the drug. It's prescribed as an office-based treatment for outpatients with a 30-day prescription. So it's much easier to maintain good function and less disruptive than with methadone. But a special X waiver is required with an 8-hour training to be able to prescribe for opioid use disorder. And there's a lot of confusion about this, so I want to explain a little further what an X waiver actually is. So according to the Harrison Narcotic Act of 1914, which came about in order to restrict the trade of opium and heroin that Bayer Pharmaceutical introduced to the market in 1895. It was made illegal to produce, import, manufacture, compound, dispense, sell, or distribute opium or its derivatives without registering and paying a tax. And you were exempted if you were a physician, dentist, or veterinarian who was personally attending a patient, which all sounds fine. But then in 1919, just 5 years later, Webb versus the United States interpreted this to exclude prescribing for patients for maintenance of a drug habit. So you could not prescribe opioids to a habitual user in an attempt to cure their habit. Or in other words, you could not prescribe opioids for the treatment of opioid use disorder in a patient who is addicted to opioids. And this was true until the Drug Addiction Treatment Act of 2000 came along and waived the violation for physicians if they met criteria, including the specialized training for prescribing buprenorphine for maintenance therapy for patients who had opioid use disorder. So that's what an X waiver is. And so once daily dosing is what is evidence-based to prevent cravings. So that's the dosing interval for the treatment of opioid use disorder. But it can also be prescribed by any prescriber off-label for pain. You just have to prescribe it more than once a day in order to be able to prescribe off-label. And then naltrexone. Naltrexone is a full antagonist. It has once daily sub-Q injection as its administration. It has less evidence for efficacy than methadone or Suboxone, but it's the best option for highly motivated individuals who are unable to be maintained on a full agonist for job reasons or for probation or for whatever. But they have to have really good support systems to be able to remain compliant with naltrexone. And then there's detoxification. That's an option, but it has the worst outcomes, meaning that it has the highest failure rate and return to misuse, overdose, or death. Rapid tapers are the most problematic with detox, with the highest risk within the first 30 days after discontinuation. And so this is a graphical representation of a treatment effect. So when a full agonist like methadone binds to the opioid receptor, you have a dose-dependent effect. There it is. The higher the dose, the higher the effect, and there's really not a lot of ceiling. Heroin is also a full agonist, but it's got a very quick onset, which is what causes the euphoria on administration. But methadone has a very slow on and off, and so you don't see the full effect of yesterday's dose until tomorrow. So then when an antagonist like naloxone or naltrexone attaches to a receptor, it blocks any effect from happening, and then it competes to knock off the agonist, whatever agonist is attached. So it can precipitate withdrawal in patients who are chronically taking opioids. And then when a partial agonist like buprenorphine binds to the receptor, you only see a partial effect no matter how much is given, which is what we call the ceiling effect. And it also competes to knock off any agonist that's attached to the receptor. And so it depends on whether the opioid effect is higher or lower as to whether it precipitates withdrawal or rescues from withdrawal when it's administered. So this is a graphical representation of the failure rate of detoxification. So it was a small Swedish study. It was only 40 patients with opioid use disorder, but they did not meet criteria for methadone maintenance. And so they randomized to buprenorphine, 16 milligrams per day ongoing versus 6 days of buprenorphine followed by a taper. And then all patients participated in behavioral therapy and counseling to prevent relapse. They received weekly individual counseling sessions, and they also had supervised urine drug screens to detect illicit drug use. And so the primary endpoint was the 1-year retention in treatment. And you can see that none of the detox group remained in treatment versus 75% of the buprenorphine maintenance group. And the whole control group dropped out by 2 months versus only 1 of the treatment group. So that's the effect of the different therapies. And this is a little more about buprenorphine specifically. So it comes in a sublingual film or tablet. That's the most common administration formulation. It's got minimal euphoria, sedation, or impairment. Its mechanism of action, it's a mu-opioid receptor partial agonist. It's a kappa antagonist. So kappa agonist is hyperalgesia and dysphoria. So an antagonist is less hyperalgesia, and it has an antidepressant effect. It has high receptor affinity, so it easily displaces a full agonist. Peak serum concentration is about 1 to 4 hours, and the half-life is about 1 to 3 days. Maintenance dose is 16 to 24 milligrams per day with a 32 milligram per day max. It's got hepatic metabolism. It's 3A4 metabolism to norbuprenorphine, which is an active metabolite. So you need to be cautious of 3A4 inducers and inhibitors. It's got a low street value. Its main purpose on the street is used for detox. And then good luck finding a ceiling dose for buprenorphine for the morphine equivalent dose. This right here was from the 2016 table from the CDC, but it's been removed from the most recent version. Equivalence dosing ranges anywhere between 5 to 30 milligrams, 5 to 30 depending on the source. But when I took the X-Waiver training course a few years ago, and multiple lecturers said that their experience was you could achieve about 120 morphine equivalents per day with 24 milligrams of buprenorphine. So that's about a conversion factor of 5. But the reason that this is so variable may be explained by the partial agonism that has a dose-dependent effect. So this demonstrates receptor occupancy at increasing doses of buprenorphine. The columns represent superior to inferior transverse sections of the brain, and the far right column in the brain imaging is the sagittal view. So the yellow is empty receptors and the purple is receptor full saturation. And you can see that increasing receptor saturation in a dose-dependent manner with almost complete saturation at the 32 milligram dose. And as more receptors are recruited, the effect of it increases, but it's not a linear response. And so although it is dose-dependent, it's not linear. And so while some people may argue that medication-assisted treatment is just facilitating getting high, I don't believe that this is supported by the medical evidence. So this is the visual depiction of how I interpret what these authors that I just showed described. And I think it's kind of easier in pictures, but they didn't include any, so I just made some myself. So this box represents the spectrum of mood, with normal being the middle in green, and extreme euphoria is in blue, and extreme irritability is in red. And so without the influence of opioids, just normal fluctuations in mood occur with endogenous dopamine release. And then with acute use intoxication, there's a huge dopamine surge that then wears off back into the normal range. But after use becomes prolonged, you have receptor downregulation and less endogenous dopamine release. And so you need more dopamine input just to maintain within the normal mood range, which is the mechanism behind severe cravings that develop when you use opioids chronically and then you're abstinent for a period. So buprenorphine or methadone, they provide continuous stimulation so that you remain in that normal range to avoid the euphoria, but also avoid the irritability. Methadone because of the long duration of action and onset, and buprenorphine because of the partial agonism. And these neurobiologic changes in the dopaminergic circuitry last years, decades, sometimes even a lifetime, depending on the duration of misuse. So to stop buprenorphine therapy, medication-assisted treatment, to me, I look at kind of like telling a patient with diabetes, you're going to stop their insulin. They just need to quit eating so much sugar, and you're not going to give them insulin. But you don't do that because you're trying to prevent end organ damage that is associated with elevated blood sugars. And I view that the same way with buprenorphine. You don't tell people you just need to quit using drugs. I'm not going to give you buprenorphine, because you're trying to reduce the cravings and all of the harmful patterns of use and harm that comes to them if they continue to misuse opioids. The high-risk behaviors, prostitution, IV injection, all those things that come along with it. But I'll grant you that agonist or partial agonist therapy is not as benign as insulin. It possibly does have some abuse potential. So what is that potential? This was a survey of 300 adults with diagnosis of opioid use disorder who were questioned about their buprenorphine use. So 58% of respondents reported use of diverted buprenorphine, and a third of those had never had a prescription for it. So those were new users of buprenorphine. And the question was, why? Why did you use buprenorphine? And the majority of respondents gave reasons that are consistent with therapeutic use. And 79% of respondents said that it was to avoid withdrawal, followed by maintaining abstinence. They had limited access to their preferred drug, or they were trying to wean themselves on their own. And you'll see that about half said that they were trying to get high or alter their mood, but most of those said it was because their drug of choice was not available. And there was only actually a couple of % of patients who said they actually preferred buprenorphine over other drugs. And interestingly, about a third of users used it to treat their pain, and less commonly they used it for depression or other psychiatric symptoms. So while there is indisputably diversion and misuse, it's most commonly consistent with therapeutic reasons to use the medication. It's used when the drug of choice is not available, and it's almost never the drug of choice to get high. And the last thing I would say in support of doing everything that you can to maintain patients with opioid use disorder and medication-assisted therapy is that it may not be a perfect solution or even a great treatment, but it's definitely the least worst of what alternatives we currently have. Because there's really only 3 outcomes for a patient with opioid use disorder. You either get treatment, or you keep using, numbering in the millions of people, or you die, like 71,500 in 2020 and over 81,000 in the years after that. So for those you encounter who are already in treatment, we need to do everything we can to support that and to facilitate them staying in treatment in the perioperative period to avoid relapse. And then for choices of medication, a partial agonist is probably better than a full agonist that requires daily supervised dosing, even though methadone has a higher retention in treatment than buprenorphine does. Or it's probably better than an antagonist that has very low retentions in treatment, but all of those are better than detox, which has no retention in treatment. So in summary, buprenorphine is recommended for the treatment of opioid use disorder. The four goals of treatment are to suppress opioid withdrawal, to block the effects of illicit opioids, to reduce cravings and stop or reduce the use of illicit opioids, and to promote and facilitate patient engagement in recovery-oriented activities, including psychosocial intervention. So there's ample evidence for use. And it's significantly lower risk for overdose compared to a full agonist like methadone. And I'd remind you also compared to discontinuation. But it is worth reminding that it has such a high affinity for the mu receptor that it will displace a full opioid agonist and precipitate withdrawal if insufficient time has elapsed since use. So initiation shouldn't occur till about 6 to 12 hours after a short-acting drug, or 1 to 3 days after a long-acting drug. And using the clinical opioid withdrawal scale with a score of about 11 to 12 or more before you initiate the drug is sufficient degree of withdrawal before you initiate someone in therapy. So now moving on from opioid use disorder to pain management and what we do for pain management in patients who come in for surgery. I would say that if you follow the same basic strategies that you would for any other patient who's having surgery, we have multiple consensus guidelines that would support that strategy and kind of telling us what that should be. So these are 6 expert recommendations that were all published within the past 10 years, and they have a remarkably high degree of agreement on how to achieve optimal pain management. So we need to apply these with a little bit of logic to figure out what the most optimal thing is for the patient that's sitting right in front of us. So the guiding principles are summed up in the most recent recommendations by the ASA. You want to do preoperative risk stratification, assessment, education, multimodal analgesia, reassessment, and consultation. And by the way, all these recommendations are covered in the BSWH pocket resource for evidence-based pain management and responsible opioid prescribing that was released in 2018 and it was updated in 2021. And so what you see here is a general template, but that pocket resource has a very explicit and prescriptive algorithm, and you can find it both in print. It's available in the front office anesthesia offices, or it's also available on SharePoint under departments and pain management and opioid prescribing. So it covers preoperative assessment and preparation, communication and education, multimodal analgesia, starting with non-pharmacologic, then moving on to non-opioid first, second, and third line medications. Then it progresses to opioids. Then it has reassessment and risk stratification for opioid misuse and overdose. And then it recommends specialty consultation when needed. But the first place to start is educating the patient on your expectations for surgery. This is the modified FACES scale. It's a functional pain scale that we use here. It's not used for assessment, but for educating patients that we think may have trouble with pain control. It helps us communicate that having no pain is probably not practical after a major surgery, and it often leads to bad outcomes from excessive pain medication like sleepiness and respiratory depression. But then on the other hand, the pain score of 10 doesn't allow you to function in a manner that promotes good recovery. So our goal is that you're going to have some pain, but that you're going to be able to function in order to promote healing. And the Explain RX initiative from a few years ago helps cover the necessary components of education that you expect a patient will be sent when you expect them to be sent home on a prescription. And those expectations are that pain and soreness are normal after surgery. We plan to limit opioids. We want you to take acetaminophen and ibuprofen on a schedule. Normally, patients need prescription pain pills for about X number of days for breakthrough pain. Be careful when taking these because they can have risks and side effects. And then if you have leftovers when you're finished, get rid of them. So the rest of that algorithm gets a little more complicated when a patient comes in already taking an opioid partial agonist or an antagonist that may make our opioids that we're giving for breakthrough pain less effective. And just like the opioid crisis as a whole has kind of evolved and grown over the last 2 decades, so has the number of patients who are going to be coming into treatment and then are going to be coming in for surgery. So in 2017, the ASA endorsed one of the earliest recommendations published on how to manage these patients, which is this one. And they were actually very prescriptive and detailed in their recommendations, maybe too much for that early of a stage of seeing those patients. At a glance, their algorithm gave recommendations for elective and emergency surgery that were classified as minimal to no pain or moderate to severe pain, and had recommendations for both of those patients that were still taking buprenorphine and also those who had already been weaned. And the main recommendations of interest included this: maximizing multimodal treatment options, regardless of buprenorphine status or severity of pain expected, and giving recommendations for weaning patients preoperatively if they're having surgery with the expectation of moderate to severe pain. And then for emergency surgery, I thought it was interesting. For surgery with moderate to severe pain, they recommended to discontinue buprenorphine in the perioperative period and start a PCA. You can see these flow charts are pretty complex. They're very prescriptive, again, which is hard to remember and reproduce consistently without looking it up every time, which I know you'd probably don't have time to do. So in 2018, the American Society of Interventional Pain Physicians endorsed this guideline, and they included 12 articles in their analysis and could only draw limited recommendations. But their main takeaways were that this is a complicated issue, that management should be dependent on several key issues, including the nature of the surgery, namely their postoperative opioid requirement, elective versus emergency surgery, patient characteristics, formulation of the buprenorphine, the indication of buprenorphine, or whether it was buprenorphine naloxone combined therapy, meaning whether it was used to manage pain alone or whether it was being used to manage opioid use disorder. And when you get into the details, they were really comprehensive in their multimodal analgesia recommendations, as well as monitoring for safety. But then they made these recommendations here: to discontinue buprenorphine for several days prior to surgeries with expectation of moderate to severe pain with high opioid requirement, and abruptly discontinue them for emergency surgery with intermediate to high opioid requirement. Although they did specifically mention to try and coordinate this with the primary prescriber. So then in 2019, a group from Harvard and Toronto, with endorsement by multiple Canadian societies, looked at whether there was a difference in outcomes in patients taking buprenorphine for elective versus emergent surgeries, the dose versus the formulation that was used, continuing versus discontinuing the drug, escalating the buprenorphine or switching to a full agonist. And they found weak evidence for any of it because there just was not a lot that had been published about it. But the main takeaway was that buprenorphine should not be routinely stopped. And they identified the following risk factors that were associated with exacerbation of opioid use disorder in the perioperative period. If you discontinue buprenorphine prior to surgery, induction of a full opioid agonist in the place of buprenorphine prior to surgery, because that triggers relapse. Shorter durations of buprenorphine for treatment of opioid use disorder, again, because of that long-lasting brain circuitry that we talked about earlier. You have, if you have evidence of aberrant use, like a positive drug screen or something like that in the recent past, because they're already prone to relapse. If you have discharge from the perioperative period without maintenance on buprenorphine, and insufficient communication with the patient's outpatient buprenorphine prescriber. So their recommendations were all designed to reduce the risks, and they were very similar to the prior ones, except without the recommendation to quit buprenorphine therapy. So then in 2020, the American Society of Addiction Medicine and the they published this national practice guideline where they addressed buprenorphine goals of therapy in general that we already discussed. And then they addressed two special patient populations. First, patients having surgery, and then patients with pain just in general. So they're coming from the perspective of patients with long-term addiction, for relapse prevention, harm reduction, et cetera. So for patients having surgery, they say that discontinuation of methadone or buprenorphine is not required. And this is because, again, of the risk of relapse. And they also address the main general principles that we talked about earlier for optimal perioperative analgesia using those multimodal strategies. And secondly, the general considerations for patients with pain included risk stratification, discussing and coordinating with their buprenorphine prescriber, assessing and diagnosing correctly and treating their side effects, educating on realistic expectations, using multimodal analgesics, starting with non-pharmacologic, proceeding to non-opioids, first, second, and third line, then proceeding on to opioids. And for your breakthrough pain, they talked about buprenorphine escalation, and that can either be increasing the dose or increasing the frequency or doing both, or transitioning them over to a full agonist. And then reassess and treat your side effects, and then consult like APMS for regional analgesia or physical therapy to maintain good physical function. And then specifically for acute pain management, they gave recommendations to increase the dose by about 20 to 25%, or split the doses into 3 to 4 times per day, noting that the duration of analgesia lasts about 6 to 8 hours versus their treatment for opioid use disorder, which is for the cravings, which lasts about 24 hours. And they went even further to suggest that maybe methadone or buprenorphine could be considered for patients with both opioid use disorder combined with conditions that are painful simultaneously. Sorry, I didn't move on. So finally, in 2021, this recommendation was endorsed by the American Society of Regional Anesthesia and Pain Medicine, the American Society of Anesthesiologists, the American Academy of Pain Medicine, and the American Society of Addiction Medicine. And their recommendation is basically the same as ASAM, but they have a little bit more detail. It's a straightforward and logical approach that's supportive of maintenance therapy, and it exhaustively approaches the multimodal treatment strategies. It recommends continuing buprenorphine as a general rule and treating with all the non-pharmacologic and pharmacologic non-opioid adjuncts. If there's uncontrolled pain with that approach, then you can slightly reduce the buprenorphine dose and add a potent agonist for breakthrough pain, and then follow-up should be coordinated at discharge with their primary prescriber. And for non-opioid management of moderate to severe pain, I would also like to emphasize that we have that low-dose ketamine for analgesia protocol here. It's an order set that is one click to initiate the order set, and it's very effective. It's IV, it's a non-opioid analgesic used to treat moderate to severe pain, and it has the added benefit of resensitizing patients to opioid-related medications. And so it can reduce opioid hyperalgesia and improve their opioid pain relief after you resume that medication. It can also be used to mitigate opioid withdrawal symptoms and if opioids need to be weaned. So if you have an extremely complex patient, it's a great option to consider while you're trying to figure everything else out. But what I really like about this paper is that it kind of goes one step further in recommending what I really kind of advocate for when I see patients in consultation who have opioid use disorder or who you may suspect of misuse. And that's if you identify them in the perioperative period and they're not already in treatment, it's a really great time to intervene. As physicians, we need to have a global perspective of health and not just think of ourselves as the person who's going to operate and fix an operative problem, but to intervene for their overall well-being moving forward. And discharging a patient with opioids that we know or suspect has opioid use disorder or has high risk for misuse doesn't leave them better than we found them. And so the perfect time for wellness intervention is while they're here as an inpatient or in the perioperative period. And so ASAM is probably the best source on how to initiate buprenorphine therapy. They recommend, again, a COWS score of 11 to 12 for most opioids before you initiate buprenorphine therapy to make sure they have reached a sufficient level of withdrawal to rescue them out and you don't precipitate withdrawal starting the buprenorphine. The initial dose is 2 to 4 milligrams. Initial observation is 1 to 1.5 hours. You would incrementally increase the dose by 2 to 8 milligrams. And your therapeutic goal for dosing is about 16 milligrams per day or higher, or until they've reached a stable effect and that's well tolerated for 24 hours. Maintenance dose is about 16 to 24 milligrams and maximum is 32 milligrams, but the 32 milligrams has a higher diversion potential, so just use caution with that. And then the side effects include headache, anxiety, constipation, perspiration, lower extremity edema, urinary hesitancy, and sleep disturbances. And prolonged QT is listed as one of them, but at the doses that we use it for, that's not really clinically significant. So naltrexone is a different story because it's a competitive antagonist. ASAM recommends discontinuing oral naltrexone 3 days before surgery and discontinuing the extended injectable version, the 30-day version, about 30 days before. You want to use caution when you initiate opioids because they can be hypersensitive to the effect of opioids when you first start administering them after they've been on naltrexone maintenance for a period of time and now they're off. And then reinitiation should occur when opioids have been completely weaned because of the risk of precipitating withdrawal. And so if that those last few slides just kind of blurred together, then this is what it boils down to. For known opioid use disorder already taking buprenorphine, buprenorphine should not be routinely discontinued or tapered in the perioperative period due to the risk of opioid relapse or harm. Multimodal analgesia should be maximized with acetaminophen NSAIDs and kind of the second and third lines as necessary. You want to escalate the full mu agonist with high affinity for the mu receptor if needed to achieve adequate analgesia. And in most cases, you should avoid tapering anything. When you escalate, which one should you use between morphine, hydromorphone, fentanyl? Fentanyl has the highest affinity for the mu receptor, but it's very short acting. It's highly reinforcing, which can trigger relapse. And so although hydromorphone is more reinforcing than morphine, it's less reinforcing than fentanyl and probably is a better option than morphine. It's been successfully shown to overcome buprenorphine's blockade at higher doses, and at the dose equivalent, it's probably better analgesia than increasing the buprenorphine dose. So in other words, they showed that hydromorphone at increases up to 32 milligrams orally is better than buprenorphine at increasing doses up to 32 milligrams orally, but hydromorphone had higher adverse events associated with it than buprenorphine did. And it looks like it's frozen. There we go. All right. So then buprenorphine can be increased or divided in the doses to achieve adequate analgesia. You can consider initiating buprenorphine with dose escalation of at 4 milligram increments to a soft maximum of 24 milligrams or really a hard maximum of 32 milligrams. If a full agonist is initiated or buprenorphine is increased, provide a plan for the taper back to baseline. You want to engage their prescriber. And if you suspect opioid use disorder, consider initiating buprenorphine for postoperative analgesia or for those who are at high risk of misuse. And then you can refer them at discharge. And so these are some of the resources we have through the Baylor Scott and White system. You can consult addiction psychiatry while they're an inpatient. You can refer them to Be Well, Texas. That's no cost opioid use disorder treatment if you've started buprenorphine in a patient who can't afford maintenance therapy as an outpatient. We have outpatient buprenorphine management for the entire Baylor Scott and White Health Network. With the capacity for video visits, and now we also have funding through the SHOUT program to care for some of these patients who are not able to pay for the maintenance therapy on their own. And then there's More Narcan Please, which provides naloxone at no cost to patients to help reduce the risk of overdose death from high-dose opioids. And these are most of my references, but a few of them were on the slides, but I'm happy to provide references on request if you'd like them.